একদম।
Yes, welcome, Dr. Gopinathan. Ultimately, I could see you.
এসছেন স্যার?
Yes, he has joined. He has joined with the camera. Yes, I think his net was problem. Yeah, Gopi has joined. Yeah, Jijida is also joining. Jijida is already joined. Yeah.
স্যার, we are live.
Okay.
Start.
So today we are going to discuss about what are the options in revision ACL, because revision ACL, whenever some index surgery has failed and young guy has come with whatever, he is not very happy, he cannot do his sports activity. Even sometimes the ACL is not only indicated only for the is needed only for the sports, because the way we travel in our country, that we have to travel in the your loaded buses and trains, probably that is the hardest post we have to face every day. So ACL is needed for all young people, and I think below 45 everybody will agree that ACL is not that. Some there are theories like copers and non-copers, but the who is not going to cope up, he has to be done with the ACL. But sometimes we probably it is done in the ways this mentioned, like your anatomical, non-anatomical, whatever way, but still sometimes the ACL fails. Might be because of the poor surgical technique, might be the poor graft, might be the poor tunnels, might be the poor rehab, or sometimes the overzealous activities. And people sometimes we say that repeatedly that you have to join or you have to go to the sports for after 9 months, like that. Some people are not listening to whatever the surgeon is advising. So lot many factors are involved in the failure of the ACL surgery. And also there are some problems with during the ACL surgery, we cannot diagnose the problems with the ACL, like your concomitant meniscal tear, meniscal root tears, or the extra articular like your collaterals. Sometimes there is lax PCL. So many. The ACL surgery not looks like very simple. You just go in and do a ACL. So we are really honored that we have got the real stars of our country, like Dr. Kanchan Bhattacharya, who was the past president of our Indian Arthroscopy Society, and also Dr. Gopinathan. His name is that much because Gopinathan, I think, is a great name throughout the country in our arthroscopic field, and is a very, very close friend of mine. Whenever I call him for any meeting, he had never told me no. He had never told me no. Another I respect, like my elder brother. He looks much younger than me, but believe me, he is older than me. By 3 years, he is senior to me, but looks like 10 years junior to me. He is Dr. Gigi Kaur, and he is academically extremely sound. He is reading, he is just like an encyclopedia in his brain. Okay. So, and he's the pictures he draws and the computer, every time we go for the how to do the PowerPoints, he's a master in that. And also our young guy is from Delhi is there, Vikram is there, and Vikram is doing great job in ACLs, and he is doing some of the ACL revision surgery also. So we have got 4 faculties here. So I think Kanchanda, being the most senior in our faculty group, he will take the whole lead of the program. Me and Arnab, who is the youngest in the young faculty in our from our Kolkata, and he is really looking after all the ITs, like our all programs from Kolkata itself. And the today's program, whatever is done, because of whatever is possible from West Bengal nowadays, 90%. 99, if I'm not wrong, more probably 100% done by Arnab. He is doing all this. This is a great learning during this pandemic period. So Kanchanda, he will lead the whole program. He will be the moderator, like your headmaster of the whole program. Thanks to now it is over to Kanchanda.
Thank you, everybody, especially thanking Gopinath that has managed to join with difficulties, and Gigi is also joined. I also invite Vikram and Jiten, who's going to join us and is going to add to the strength of the faculty here. Arnab has always been doing a great job at organizing these meetings, and this is not going to be any different. So I think we have a different set of people who are going to log into this meeting. But by and large, it's going to be people who do ACL or revision ACL. And I think we can freely go ahead and speak our minds, knowing that people who are listening to it are completely cognizant of what's happening around. The way it has been organized by Shonendo is that Gigi Kaur is going to speak about the investigations, And then Gopinath is going to give us a view about how to plan the surgery. And I'm assuming that he's also going to speak something about the reconstructions as well. And then I'm going to speak about some additional procedures if and when required. Vikram is going to present 3 cases. And we are going to look at everybody to put in your inputs, ask your questions, and make it as interactive as possible. So, Arnab, it's up to you now.
Yes. Thank you, sir. So I think we'll straight away start our scientific discussion. So first, our respected Jidikar sir. So I'll request.
Yes, sir.
Yes.
Okay. Fine.
Yes. Yes.
You can start your screen share.
Can I share the screen? Yeah.
Yeah,
Yes.
yeah. Now, you mute everybody or not, so that
Yes.
there is no background noise when somebody is presenting.
Yes.
Okay. Even the faculties, they have to be muted,
Yes.
and only the yours and the Dr. Kaur's sound will be on.
Okay, sir.
Just a minute. Okay, so
Yes, go ahead. Yes, it is done. It is coming.
it's going into full screen mode, I think.
Yes.
So somebody has come up with the nicely done or maybe poorly done ACL, and it has failed. So you have to investigate how it has failed and what are the steps you can take to make it a success by a revision ACL surgeon. So investigations are basically done by detectives. Think yourself as a detective. What are the problems that led to the failed ACL? What is a failed ACL? There are controversies about the definition. Simply put together, that we expect after an ACL reconstruction, successful ACL reconstruction, that it will be stable, painless, and fully mobile knee joint, fully functional knee joint. If there are deficiencies of these, then we can call it a failed ACLR. For instance, ROM loss, pain, and of course infection. For today's purpose, because we are thinking about revision ACL reconstructions, which addresses mainly to the top problem, not the other 3. So we concentrate our discussions on instabilities after ACL reconstruction. This is a classic chart, classic pie chart in a Mars study, that there are main 3 areas of causation of the failures, etiology of the failures: trauma, technical problems, also you can call it day 1 failure, and the biology, late failure. Why do we need to investigate? Look upon 3 P's. First P is the pickup, to pick up the etiology. Some parts of the etiology can be modified. If it is modifiable, you must modify it. Otherwise, you'll be doing the same mistake as the first surgeon. Maybe the first surgeon was you or me. If it is modifiable, then who can modify? Is it the patient? Is it the surgeon? Or is it the physiatrist and rehabilitationist? That has to be determined. There can be multiple factors which can be modifiable. Some of the factors may not be modifiable. In that case, you have to have a plan. Second issue with the investigation is for planning. What will be your rehabilitation? What materials will you use? What instruments will you use? What methods you will employ? And what will be your rehabilitation protocol after this second ACL reconstruction? And also to prognosticate. At the back of your mind, you will think that this particular revision ACL is going to last, is not going to last. You have to convey that to the patient also, depending on the investigations of failed ACL. So again, a detective, you start with listening. Is a from the witnesses like that. You listen And after listening, you think about this, what the patient, he or she has told you. And after thinking, you can put another question, a battery of questions, pointed questions that will lead to further listening, okay? And this is the process by which you can come at a working diagnosis from the history itself. Much of the diagnosis can be from the history itself. So you rethink. After this process comes the examination and imaging part. So it's a stepwise procedure. First, your history in 4 phases. Then you examine the patient, including the knee joint and excluding the knee joint also, beyond the knee joint also, will come to that, and go for imaging. History is the most important investigations. Unfortunately, because this is the free investigations, sometimes we do not have enough time to listen, to examine, and to come to a working diagnosis by thinking. Then we can miss what is in the costliest of investigations as well. So the first point is, when did it happen? Was it acute failure or a gradual failure, gradual stretch out? How did it happen? And how frequently is the episodes of instability or insecurity? Sometimes the patient may have feelings of insecurity, but objectively when we examine, you don't have any telltale signs. In those cases, we'll be very skeptical about doing an ACL revision. Now we are talking about this second injury, but history, this is the usual way we start, but the history should start at the prehistory. Prehistory means not in the prehistoric age, but at the first instance of the index injury. Age at index injury. Studies have shown that the earlier the age, the younger the patient has the index injury, there are higher chances of failure even after ACL, even after revision ACL reconstruction. Just like your shoulder dislocations, the younger the patient at the time of index shoulder dislocation, there are more chances of having repeated dislocation in the future. Then you must have the details of the index injury. If somebody comes to me with a revision ACL and do not provide any detail of the index injury or the index surgery, then I beg of him that please find another surgeon. I'm not competent enough to go for a revision surgery in your case. Injury surgery interval is also important because there can be deconditioning of the muscles around the knee joint and even in the trunk for an amateur athlete or for an elite athlete. That can be deleterious, and your well done revision reconstruction may fail. Then, of course, the details of the index surgery, how it was done, what are the materials the surgeon has used. Maybe you are the index surgeon also, then you can know that, and the images from this index surgery. Then, what were the rehab protocols followed, whether it was actually followed, and the activity level achieved by the patient. The higher the activity level achieved by the patient after ACL reconstruction, the higher the chances of revision ACL requirement, unfortunately. So in the method, whether it was a physis sparing extra articular methods or it was a transportal or transtibial, you have to know. So for the material is concerned, whether an allograft was used, we do not use allografts. Allografts fail more than autografts. Especially below 25 years of age, soft tissues fail more than the bone patellar tendon bone graft, and ladies also, soft tissues fail more frequently than bone patellar tendon grafts. The images from the first surgery, after the first surgery, if you get this kind of images, you can know what was the problem. If you have this kind of images, you know what are the problems. I'm not going to details of these. Again, tunnel placements and the slope. Here, you can follow the cursor. The endobutton is in the quadriceps muscle, and when the muscle gets necrosed, it has become loose. And this is one of my patients. You see, this one, bone patellar tendon graft. The graft has dislodged into the joint. It was fixed by a bio screw, and it has dislodged into a joint. This is about 16 years follow-up. The patient has refused surgery, and sometimes he calls me up. Every time I get scared that he will tell me that something has happened. So far, nothing has happened because he has stopped playing. That is important. He has modified his activities not because of this, but because his dad died and he had to look after the business, family business. So again, in the prehistoric stage, the first image can be very diagnostic. Here there was a PLC injury, it was missed, and the ACL was, only ACL was reconstructed, and basically that is bound to fail. The clinical examination is the next most important. We all know how to examine the knee joint. I'm not going to details of that, but we must be looking beyond the knee joint in case of if you plan for a revision ACL reconstruction. The core strength, the quad strength, and the alignment of the three basic things we must look into. In these, we need just a basic of biomechanics. Don't go anywhere. I'm not going to bother you with sine thetas and cos thetas. This basic thing is that in the normal biomechanics, trunk and core muscles, quads and hams, ligaments act in unison. Even the leg and foot muscles act in unison to keep us upright, to keep us dynamically, functionally moving. And there is symmetry between our right side and left side, inbuilt. Of course, for footballers who use one leg more than the other, there can be some kind of asymmetry, which is adaptive asymmetry. When the biomechanics become abnormal, then there can be a trunk dominance, quads dominance, ligament dominance, and leg dominance. Leg dominance means side dominance. One side is slightly more dominant than the other. In those cases, you have to have dynamic testing, functional testing, and if you're really serious enough, sometimes you have to go to the field even to observe the patient, how does he or she runs, jumps, etc., with the injured, repeatedly injured or failed, one knee has failed. Sometimes both knees fail. That's a different issue. You have to have an idea about the strength, flexibility, reflex, and coordination in case of athletes. And as Sharun has already pointed out, living life can be a sport. Dr. Joshi has stressed on that about, I think, 25 years back, that life is a sport over here. This is an 11-second video, drop vertical jump, that can tell you many things which can be simulated in your office clinic. You see, this is the jumping, and one more jump, drop vertical, right? So look at this. Another one. Okay. The point is, when she jumps in frontal view, you look at this. Look for any varus here or any extra valgus here, and the rotation of the foot. Internal rotation of foot, any varus or too much of valgus places the ACL and other structures also in deep stress. And if there is significant asymmetry between the knee joints, then you have to address that also. Those are modifiable factors. This is from the lateral side. Okay. Here you look for the low knee flexion angle and the recovery time. On recovery, whether there is a hyperextension and the trunk position. In the next slide, will explain that. This is the knee flexion angle on landing. This is the maximum knee flexion angle and the position of the trunk, whether it is well balanced or not. And this is on the recovery, whether there is a hyperextension of the knee joint or not. If these things are present and you do your revision ACL perfectly, then there's a possibility that because of these erroneous positioning of the patient, the revised ACL can also fail. So correct those things and at least make the patient aware of these faults. Then you go for testing the single limb stance on unstable that can unmask your dynamic valgus, dynamic varus. You will also look for gluteus maximus large and if there is a functional trembling. Then you come to the knee, of course, there is a standard battery of tests for ACL. We are not going to detail of those. sometimes it happens that there are no objective instability, even with a testing by an experienced clinician, only subjective insecurity. In those cases, think twice before doing a revision ACL reconstruction. Take the patient in your confidence and go for rehab once again. Then there can be signs of inflammation. Examine the PLC, examine the MCL. Those are basics, but just for interest. Then we look also for the Batten scores and the generalized ligamentous laxity, whether there is presence of these or not. Then, of course, you have order new images. X-rays, you look at the tunnels, you look at the hardware, and in intracondylar notch view, you assess the width of the notch and the height of the notch. Then a maximum extended true lateral, the tunnel versus the Blumenstadt's line. Where is the positioning of the tunnel, whether it is coinciding with the Blumenstadt's line or not. This is the maximally extended true lateral view. And alignment X-ray. If there is if you suspect from a clinical examination that there is an alignment problem, you also can have this alignment X-ray. But sometimes it can be a false, it can give you a false sense of security because the patient is only standing over here and the ACL is ACL has been put on the stress during function. In these functional cases, the functional assessment of varus or valgus is by clinical method, not by radiological method. Of course, the CT will tell you how much the tunnel has widened and what is the bone structure just beyond that tunnel, because you are thinking about fixation. You have to have a good idea of what is beyond this widened tunnel. Even with a good tunnel, not widened tunnel, there can be poor bone structure beyond the tunnel. And of course, the tunnel positioning, width of the notch and osteophyte in the notch, you have to assess. MRI, you assess the synovium, which is not visible in other investigations, except perhaps clinical examination. You also look at the articular cartilage. If there is a delamination of the articular cartilage, then also you also tell the patient that the joint has degenerated, is going to degenerate. In spite of a stable knee, it can be painful in the future, maybe slightly stiff. Then you assess the ligaments and the PLC, and that almost concludes your assessment of the knee joint. So in a capsule, you think like a detective. What caused the initial injury? What caused the initial rupture of the reconstructed ACL? So what happened after surgery, that is also important, how the rehabilitation has done, what was the activity level achieved after that, and trauma. If it is a traumatic, then there is a different plan. If it is a non-traumatic, then there is a different plan. Look beyond the knee, again come back to the knee and go for imaging. That's all.
Thank you, sir.
Okay. So I'm stopping sharing.
Yes, sir. Yes.
Yes. I think Dr. Kaur was quite elaborate on his because unless you properly, this is probably he has not only touched the clinical exam, also the radiological investigation. Also, you have to go with the prehab and the post-op, everything. You have to counsel the patient because already he has failed one surgery and you are taking another one, bigger one surgery. It is not
bigger
like
surgery and with higher chances of failure than in big surgery.
Also there is when you redo it, there is a very, very high chance of failure because if the guy is a sports person, then the failure probably multiplies with another 4 or 5 times. Okay. So I will go to Kanchan sir. So probably he has got, we have all given learned arthroscopy. We have hold his hand because he was the pioneer in this part of the country to introduce arthroscopy. So I will go to Kanchan sir to just have quick comments, and then I will go to my dear friend Gopi. So he will be giving us the planning and options. So Kanchanda, anything to add on with Dr.
I think
Ostrog? Yeah.
no. I think Gore has been completely on the ball. He's told us about everything that can happen, all that you should be looking to. I don't think there's anything to add to that.
Yes, Gopi. That's why in the introduction I told itself that yes, when Gourda is presenting something, we has to be jailed to the screen because.
Kanchan, may I make a comment?
Yes, sir, Jiten sir. Yeah, this is a great honor that you have joined, sir.
No, I'm very pleased and I'm very happy with this lecture. Very perfect. I think only one point I want to make is
Yes, sir.
a lot of time these days, patients are driven by tests, which means they have a pain in the knee, get a MRI done. The report says ACL has failed, and now it is a failure for them. They are already looking for second surgery because they've gone on the internet and everything. I think it is a very important point for a surgeon to understand, is there a need for doing anything? A lot of time it is just anxiety of the patient. You examined Lackman maybe 3 plus, it was 3 plus even 1 month before the injury, but just because MRI has been done, this patient is hunting for surgery, which you know as a surgeon is not 100%. So I think you have to spend a lot of time understanding whether this patient actually needs surgery or is it just anxiety creating out of other things. That's a part of the detective method, whether actually this patient has done something or he's just making, unnecessary halla-gulla. So that's a very important part of assessment when you're talking to the patient. What is forcing him to all this anxiety? And if I'm doubtful, I will give it some time before I jump on to ACL and then revision and then all the x-rays and all the tests. And a lot of patients you will see will understand that they're fine. It was just an MRI picture. So I think that's a very important part of the clinical history and assessment. Thank you.
Yes, sir. That's a wonderful comment. And I think the wheel has rotated 180 degrees. Previously, you had to convince the patient that your knee needs surgery because it is unstable, and instability will lead to some problems later on. And you may fall down while alighting from a moving bus. So the situation has changed that now the patient are driving the surgeons to do the surgery.
I think the problem with the ACL surgery is that I think return to play or the return to the whatever the need the guy is having, it is more complex when the guy is young, more or less when he's below 30, then the demand is already very high. You all been told before the surgery that return to play, if there is a pivoting or the cutting action involved with the ACL group, then the problem is the return to play to the original grade this should be printed in the brain. That is hardly, it is 60%. So 40% they cannot do it because they have to come down to one level down or 2 level down even. 40% falls into the group even with the well done ACL. Not because of the ACL, the quality of surgery. It is because of the rehab and also what Jiten sir was mentioning. This thing probably we overlook. There is a phobia that is known as the. I think I don't remember the exact name of the phobia. There is a term in there. I think it is a starts something with the K. The KANCHAN sir probably might be remembering that term. It's a phobia is also there because they cannot return to play because of the phobia. I might get injured again. Kinesiophobia. So this is also there. So ACL surgery failure, 60%. Remember, 60% goes back to the level, same grade. 40% they never go back to the same. So doing the ACL surgery
in your hands.
Yes,
60% in your hands.
that is not in your hand. So counseling, remember, this is for the juniors. Whenever you take the patient for your surgery, counsel and talk to him for 10-15 minutes because all these probabilities. Otherwise, he will be an unhappy patient. Kanchanda, anything to add on that?
No, not really. Not really.
Okay, so I think we can move ahead to the Professor Gopi's lecture. Yeah, so I think Professor Gopinathan, I have already told he's one of the kings in the South India. Okay. So he is not only called as a king, he is now the emperor there. So I will request our dear friend Gopinathan, please share your screen and Arnab, please mute everybody so that there is no background noise. And Gopinathan is, once he is sharing the screen, we will be eagerly waiting for his talk.
Yes. So by the time sir is sharing his screen, can I ask a question?
Yes. Any question in the YouTube we can take.
Yeah. So what is most important for a revision ACL? So identifying the cause why it failed, or just we need to concentrate more on doing the second surgery in a perfect manner. So what is rather most important?
Professor Kaur is there. Still he is there.
I'm coming to that. I'm unmuted, I think.
Yes, sir. Yes, sir.
It's like having a fever. Okay.
Yes.
Paracetamol will cure your fever. But if the cause is still there, then it will come back. Okay, so paracetamol is the perfect revision surgery, and the hunting for the cause is your hunting for the disease, for the what caused the fever in the first place.
So the thing is that we should give more.
Both are important. Both are important. If you only diagnose the cause and don't give paracetamol or the specific antibiotic or something like that, the fever will not go away. So both are important. Only paracetamol is a symptomatic treatment. Just like that, only revision ACL or ACL reconstruction is a symptomatic.
Right.
I think Gopinathan's screen is there, so we can go ahead with it.
Gopi is online.
Arnab, please mute everybody there.
Mute everybody except Gopi.
Yes.
Some people are not being muted. Yeah.
Can you just like?
Yes, sir. You can see.
Yes, sir. You said Gopinathan, please go ahead.
Thank you, Dr. Sarnendu, for inviting me for this great session. I must talk on planning and options. So most of the time, we know that the facts are not revealed to the patient, and many of the surgeons does not know what the real fact is. So I'll just rush through what are the causes of failure for ACL, then plan, and then options. The published success of primary ACL surgery has been reported to range from 75 to 95%. And with this given option, we all know that a certain percent of the patients will definitely have unsatisfactory outcome, and they may finally need a revision ACL surgery. So what is the definition of a failed ACL surgery? There is a little agreement on what qualifies as a failed ACL surgery. Definition according to Cuddifu and Johnson, they say knee with a recurrent laxity or instability, which instability means it is a failure. And also, if the flexion of the knee is less than around 10 to 120 degrees, that's a failure. So if you don't achieve good flexion after surgery, which is important for activities of daily living, then again it's a failure. So failure does not mean instability always. Graft failure is the most common, but not the only cause of failed ACL surgery. We should all remember that. And we should know that non-graft related issues are also quite important for patient satisfaction. For example, the range of motion, the function of the extensor mechanism, degenerative arthritis, all can result in poor outcome. And ACL surgery, in spite of an intact and functional ACL graft, the patient may be unhappy. So these are the points we should always remember. One is loss of motion, arthropibrosis. If there is stiffness, no patient is going to be happy. So there is an extensor mechanism dysfunction, again the patient is not happy. Or there is accelerated arthritis, and the last is a graft failure. But we always focus on graft failure as a failure of ACL, but there are certain other factors also which should be considered as a failure of ACL surgery. So what is the reason for loss of motion? Mostly it is a graft impingement, a physical block in the notch or in the condyle, and then it could be a capsulitis or a pericapsular scarring or intra-articular arthropibrosis or a non-anatomic graft plate with infection or a chronic regional pain syndrome. CRPC, the chronic regional pain syndrome, is also quite an ACL surgery. So loss of motion after ACL surgery could be multifactorial. It's a non-anatomic graft placement, as I already told, excessive graft tension, overtension of the graft, or cyclops lesion. Acute injury during inflammatory phase. For example, if you do a ACL reconstruction immediately after injury, there's an inflammatory process which is going on, and your surgery is going to add another inflammatory process. So you should be very careful during rehabilitation of a patient on whom you have done a ACL surgery very early. So that's one point. Then prolonged immobilization and poor rehabilitation all results in a loss of motion and a failure. On the part of the patient, it's a failure of surgery, even though the graft is intact. So the impingement, the causes are the notch scarring, cyclops lesion, too much anterior tibial tunnel, or inadequate notchplasty, and prevents anything which prevents full extension, which results in, according to the patient, the knee or patient with a flexion deformity after to determine the etiology for loss of motion. The stage procedure after determine the etiology for loss of motion, restriction of range of motion after the strength and normal gait prior to any ACL revision surgery. So if you do a primary ACL surgery after a good range of motion, the same thing here to achieve before a revision ACL surgery also. So the loss of motion also could be due to capsulitis, like periarticular inflammation and swelling, intra-articular adhesion, scarring, and arthrofibrosis, and it results in loss of flexion or extension. It could result in a flexion deformity. Also, it could result in a reduced range of flexion as well. And it results in a restriction of the patellar mobility, which could be a patellar baja, or you can get what is called intrapatellar contracture syndrome, or a synetia between the patella and the femoral condyle. So these are the usual outcomes of capsulitis and intra-articular fibrosis. The treatment is determine the etiology of loss of motion, and there should not be any aggressive manipulation, and should be very careful when you mobilize these patients. Extensor mechanism dysfunction. The graft harvest complications were quite common when we used to do a lot of bone patella, bone tendon graft, where patellar fracture, extensor mechanism rupture, and donor site morbidity were the reasons for extensor mechanism dysfunction, and it could result in patellofemoral pain, anterior knee pain, patellar tendinitis, and avoidable intrapatellar contracture syndrome. So the patient is not able to extend the knee well after ACL surgery, amounts to a failure of ACL surgery. Another problem is an accelerated osteoarthrosis after ACL surgery. There are some studies which shows that ACL surgery sometimes results in increased accelerated postoperative anisectomy or a chondral injury which you have not detected. This could be the cause, but for the patient, it is a failure of surgery. Recurrent instability. This is one we usually talk about and discuss in most of the forums, and they are errors in surgical technique, trauma, or failure of the graft incorporation. So these are the mechanisms of graft failure which have been published very frequently. And the technical errors which result in failure of ACL surgery are non-anatomical tunnel placement, failure to address associated laxities. For example, the patient with generalized ligamentous laxity, not only that, the patient could have a postlateral instability or a medial instability or anterolateral instability which is undetected. You just do an ACL reconstruction which is going to fail. So it should be important to remember that it is the sleeves which are important, not the ACL alone. So if the sleeves are not intact and you just do an ACL reconstruction, that knee is going to fail, that ACL is going to fail. So you have to concentrate on the sleeves and associated instability. And of course, improper graft tensioning and improper graft fixation leads to failure in ACL surgery. First, we'll discuss about non-anatomic tunnel placement. Non-anatomical graft placement can result in graft impingement, which I already highlighted. Excessive graft length changes and laxity leads to failure to control rotational instability. So if there is a patient on whom you have done a surgery and it results in impingement inside the joint, and which results in a failure to control the rotatory movement after postoperatively, that ACL will fail. So biological ACL grafts can only accommodate small changes in the length of the ACL. It is not like just a rubber band. When you stretch it, it will come back to normal. ACL is not like that. The collagen graft you put in undergoes permanent damage if it is overstretched. So anterior femoral tunnel placement, what will happen in ACL surgery? ACL graft lengthens in flexion, captures the knee and limits flexion, or a progressive elongation and failure. So this is one reason. So if you put the graft too anteriorly on the femur, it fails in the due course. If you put a graft in a vertical placement, a vertical graft on the femoral tunnel, ACL graft impinges against the PCL, causing limitation of flexion, but it controls the anterior translation, and you get and so stability, but for rotary control it is not good, and so it will fail. So errors in tibial tunnel placement. If you put it too anterior, it's the impingement. If it is too medial, it's too lateral, these are all problems which leads to failure of ACL surgery. So too lateral are all reasons for ACL graft failure. So this here the graft is placed too medially. Actually, the hole has come into the medial condyle and it is too much medial and it's going to fail. we should all remember is a chronic posterolateral and limb alignment. So posterolateral instability and ACL injury are quite common. There are a few articles which have been published quite recently on a combination of PLC injury and ACL injury, or a posterolateral corner instability and ACL surgery. So this could happen due to a ligament injury, or it could be due to a limb alignment problem. So if you have varus angulation that produces high tensile loads on the lateral and posterolateral structures and the ACL during stand stage. For example, if you look at this patient, there is an opening out on the lateral side, and you reconstruct the ACL, and this ACL will undergo a lot of stress, and this is known as a triple varus. Narrowing of the medial medial tibiofemoral joint, widening of the lateral tibiofemoral joint, and a varus recurvatum. So this sort of patient, if you reconstruct the ACL, it will definitely fail in due course, because there is a overstretching of the postlateral compartment, and ACL will stretch out and it will fail. So you should know about the limb alignment, and failure to correct the mechanical axis will subject the posterolateral reconstruction, and even if you do a posterolateral reconstruction, it is not going to succeed. So you need a bony procedure. You have to correct the osteotomy. You have to do either a lateral closed wedge or medial open wedge. Medial open wedge is ideal. In varus angulated knee, clinical symptoms of instability may result from the following problems. It is mainly due to subluxation. So there is an anterior tibial subluxation, separation of the lateral compartment, that is opening up of the lateral tibiofemoral compartment, resulting in overstretching of the lateral collateral ligament, and the posterior subluxation of the lateral tibial plateau, resulting in excessive hyperextension and varus recurvatum. And this is sometimes described as a triple varus deformity. There is a varus as well as recurvatum deformity. So this is quite important in assessing the patient whether the limb alignment is normal or not. So in varus angulated knee, there is a single stance increases separation of the lateral compartment, which I already highlighted, resulting in a high tensile load, the postlateral structures and ACL, and increased loading of the medial compartment, resulting in early failure of the reconstructed ACL. So this is about the different types of descriptions on varus deformity. Primary varus, there is a tibiofemoral geometry, medial compartment arthrosis. Double varus means tibiofemoral geometry with the separation of the lateral compartment, and triple varus means there is a narrowing of the middle compartment, widening of the lateral compartment, and varus recurvatum. So this is the final outcome of an abnormal limb alignment. So the advantage for medial opening wedge osteotomy are a small incision. It does not require fibulectomy. Little risky. Little injury to the peroneal nerve, and for intraoperative period you can do it, and creates less deformity on the proximal tibia. But the disadvantages are it is a bone graft is required sometimes, weak internal fixation, slower healing, and tendency to increase the tibial slope. For ACL surgeons, the last one is very important. If you increase the tibial slope during your medial open wedge osteotomy, it is not good for ACL. It is going to fail. Most of the time when you do a medial open wedge osteotomy, it results in automatically increase in the tibial slope, which will result in ACL failure even after recurrent or repeat ACL reconstruction. So how to correct it? You should be very careful to correct the slope, and this is a big topic. I'll just brush through that. So if you open up the anterior side too much, it results in increased slope. So you try to open up the posterior part, posterior part of the osteotomy, so that you can reduce the slope. So slope reduction is also important in a medial open wedge osteotomy when you do a reconstruction of the ACL again. If you think about reconstructing the ACL with the increased slope, you can do a osteotomy first, bone graft the defect, and then go for the second ACL or a post-lateral reconstruction. Or you can do all together. So it can be done as a stage procedure or all in one procedure. Now the technical errors which result in a graft failure are graft tension. Excessive graft tension is associated with decreased motion, delayed vascularization, myxoid degeneration. That means ACL will fail. It results in recurrent instability. Excessive graft tension can lead to an over-constrained joint, increased joint contact pressure, and osteoarthritis. So over-tensioning of the graft is, should not be attempted. Attainment of the rigid internal fixation of the graft minimizes the elongation and prevents failure of the graft fixation. And this is the area you should concentrate. You should fix your graft well. Otherwise, mobilization is going to be a problem. Now, 30% of the well-reconstructed ACL fails because of trauma or over-aggressive rehabilitation or a premature return to athletics. So, at least 6 to 9 months, patient has to wait before they go to contact sports. They should be instructed well. So, even a well-reconstructed ACL will fail if rehabilitation is not good. Sometimes you get a failure of the graft incorporation, but the exact reason for all these graft non-incorporation is not known. It may be due to wrong techniques or a biological problem, but it is not well understood why certain grafts fail. So be prepared when you reconstruct the ACL again. You have to take a good history, physical examination, and radiological studies. This has been already highlighted by Dr. Jikar. I'll just brush through that. You have to take a detailed history, then a good physical examination, and joint filling. You need a stress filling. You need a 3D CT scan and MRI. This is already been highlighted, so I'm not going to the details. So the technical aspects of revision ACL surgery are graft selection, skin incision, hardware removal, prosthetic ligament removal if it has been used, and bone tunnel identification, and then reconstruction of the best new tunnel, graft fixation, treatment of the associated ligament injury, especially the sleeve. So these points we should remember. So I'll repeat again: the graft selection, the previous skin incision, hardware removal. If it is a prosthetic ligament, then you have to remove it. Bone tunnels, the old one and the new one. Graft fixation and treatment of the associated injuries of the ligaments, the collateral injuries, the sleeve injuries. The skin incision, you can make use of the old incision, and you should not put multiple scars around the knee. Use the old incision as far as possible. But you should not underestimate graft removal. Sometimes this is the most difficult part of the surgery. You should be prepared to remove the hardware. And you can leave the hardware which does not come on your way. And if it interferes with your tunnel, then of course you have to remove it. So most important and technically demanding aspect of revision ACL surgery is goal of revision surgery is to create anatomically positioned new femoral tunnel on the tibia and on the femur. The new tunnel position must not be compromised by the previous tunnel or the hardware. So hardware removal is sometimes very important. Now it is a perfectly positioned tunnel. It is sometimes easy because you can over-drill the tunnel because everything is perfect. If it is entirely incorrect, then again it is easy because you can drill the new tunnels elsewhere. Now where is the problem? The problem is in partially correct ones. If you have done a partially correct ACL tunnel and then it fails, then it's going to be a difficult problem. It's a potential for the tunnel overlap. Most of the times you all need a staged procedure because you have to reconstruct the defect first and then go for the ACL reconstruction. So these are the three scenarios you get during your ACL revision surgery. Now you have to look at the tunnels, how many tunnels are there, and then entirely incorrect, I told it's easy. Always fill the tunnel near the new tunnel. So if you have a new tunnel and the old tunnel is there, make the new tunnel. So femoral bone tunnels, which are easy, which is correct one, which is easy because you can widen the canal, the tunnel, and go for the surgery. Again, partially correct one, difficult as I told, because you have to do the grafting and then let it heal and go for the second stage. So this is a graft very good. We have option of either allograft or autograft, whichever is available. You can do. Then iliac bone graft is the option. It is easy to get and the patients are willing for that. If it's not available, you can go for, if the patient is not willing for that, you go for allograft. So you have a condition called widening of the tunnel. So it's important to do a CT scan in almost all cases where a tunnel widening is there. Get a CT scan. It's very important to get a 3D CT scan in this because then only you'll know how much widening has happened. And in these cases, you have to opt for a two-stage surgery. You have to graft the tunnel, widen tunnel, and then go for the second surgery or the revision ACL surgery, the second. So sometimes you can use a femoral head, which is an allograft, which is freely available to us, or you can use an iliac bone graft, which is if the patient is willing for that, that's a good option. We get some patients with the double tunnels when people were used. Now, no one is doing this. I think no one is doing a double bundle ACL reconstruction, but we get a few patients on whom somebody has done a double bundle ACL reconstruction, so they have a more bone loss and a single bundle ACL reconstruction. It's better to graft the tunnel and then let the bone heal and go for revision ACL surgery. So the vertical graft is again a problem. It controls the AP translation, but it fails in rotation. And this you have to do the corrections. Revision ACL surgery, the intact vertical graft is sometimes in a wrong position, but in those cases you can reconstruct the new one like an augmentation and leaving the old one there itself if it is intact. So etiology of failure are non-anatomical tunnel placement, as I already told, and the original technique may be transpedial. In those cases, the tunnel could be more vertical. So in those cases, what you do is you keep the original ACL there itself, and then augment or make the new ACL in a different correct position or anatomical reconstruction. You do not remove the old ACL if it is there and intact. Now, what are the graft options for revision ACL surgery? It's sometimes controversial. This must be the hot topic, but the suggestions are the primary procedure. If it is hamstring, you go for patellar tendon graft or the quadriceps tendon graft. If the primary procedure is patellar tendon, you go for hamstring or quadriceps tendon and or the patellar tendon on the opposite side. Graft fixation is quite important. If the femoral tunnel is drilled without difficulty in good quality bone, then routine graft fixation is enough. But if the bone is soft and the tunnel is difficult to make a hole, and in those cases you can use a cortical fixation like an endobutton. Due to weaker and metaphyseal bone, tibial fixation must always be supplemented by backup. So you need a double fixation on the tibial side always. So revision ACL surgery, reconstruction without a clear reason. This is the most difficult one to treat. You don't have a reason, but the ACL has failed. In those cases, you have to concentrate on the sleeve. It could be an undetected anterolateral instability. In those cases, you can have an AL reconstruction along with ACL. But you have a situation where there is a post-lateral instability which is undetected. In those cases, you have to reconstruct the lateral collateral ligament. You can either use a Larsen technique or a Lafayette technique to do a popliteus reconstruction and ACL. Otherwise, your resurgery of the ACL will also fail. So during revisions, you have to concentrate on the sleeves more often than the ACL itself. Another problem is a medial ligament and medial instability. You have to reconstruct or you have to reinforce the medial side and then do the ACL reconstruction. Otherwise, it's going to fail again. So rehabilitation is should be very careful. There should be aggressive rehabilitation after ACL revision surgery. Greater laxity and secondary restraints and associated ligamentous surgeries are always tricky, and you should be very careful when you do rehabilitate this question, and then avoid accelerated rehab program after a revision ACL surgery. So in summary, ACL surgery requires a motivated and cooperative patient, a well thought plan, and you should identify why the ACL has failed. Otherwise, your resurgery of the ACL will also fail. An experienced surgeon who is proficient in knowledge and technique and skill, and variety of surgical techniques are available now. Graft sources and graft fixation techniques have improved over the time, and you usually get the best result out of ACL resurgery. Thank you for patiently.
Thank you, Professor Gopinathan, for your excellent and elaborate talk, because probably you have basically hit the bullseye, because you have basically you have told what are the basic options, because the options are many, but what is the best, that we have to judge. So I think Kanchan sir, being the senior most in our group, Kanchan sir, anything to add on this talk? You have to unmute. Kanchan sir, please unmute. Yes.
I think Gopi has been wonderful. He's explained everything, and I've learned a lot of things. The only thing that is kind of probably not emphasized as much is when we make a tunnel, especially for the femur or for the tibia, and we make a second tunnel, we always try to change the trajectory. So that gives a slightly bigger hold on the next graft that we're holding, and it can be done in several ways. So a change of trajectory helps in doing if you do one stage revision. So that gives us a slightly better option at the of the graft holding at either ends. And one thing cannot be overemphasized, and that's a double fixation for the tibia.
Kanchan, the problem is that when femur tunnel is always a problem because you have got so many options. You can go even come from the outside in technique just to redirect your tunnel on the femoral, unless and otherwise, as Dr. Gopinathan has rightly mentioned, if it is a perfect tunnel, then you are in a real problem. If it is imperfect tunnel, you are lucky. But problem
No, slight, like Gopinathan says, slightly imperfect ones are the biggest problem.
Yes.
Slightly
Yes,
imperfect ones are the
because
biggest problem.
this is in between the perfect and imperfect. Then
Yes, and and for revisions, I always like, for the femur, I like the outside in.
Yes, outside, because you have the option of taking it. Okay.
Yeah.
So another one thing I just want to learn from Gopinathan, that because most of the time also because of the windshield or the whatever effect, the tibial tunnels are really big, like 12 millimeter. And then drilling the tibial tunnel, because tibial tunnel cannot be like extremely wrong. It has to be more or less like in between the two spines. So if you come ever from the lateral side just to drill it, or it is better to go with the second stage?
Now, in the tibia, again, you have to do a CT scan. If the CT scan shows huge bone loss, it is better to graft it and go for the second stage. So most of the time, tibia has got a soft bone, and this soft bone is not going to hold the re-surgery graft as well. So if it is a little enlarged, you can use the same tunnel, and then you can use a bigger graft and then go for double fixation on tibia. If it's too huge, it is better to graft it and then let it heal and go for the second stage.
So what is your message for the junior surgeons, that when to go with the single stage? Because most of the time it is safer to go with the two stage. So please give the clear message to the junior surgeons and also to us, how to plan in a very clear way, how to go ahead with the second stage and one stage.
Now you take a CT scan, and in that CT scan, if you got a mild to moderate bone loss, you can fill that graft with a BTB graft. So if the BTB is available to you, and if you are sure that the BTB will fit in with the first surgery is a somewhat perfect surgery, you make a bigger hole, and in that hole, if you feel that the graft will fit in the BTB graft, then you can go with the single stage. But if you feel that the defect is bigger, then your graft is not going to hold, definitely it is better to graft first and then go for the BTB graft again. So in revisions, always try to use BTB graft.
That means your cutoff point is like more or less 12 millimeter. If the tibial diameter in your CT scan is coming around 12 millimeter in your circle, then you are probably not going with the one stage. Because
12 and above, you have to always go for two stages. 12 and below, you can go for primary bone tendina, bone patella, bone graft.
Kanchan, there is a question for you. Kanchan, do you advocate anytime, suppose the graft, your tibial, when you done the CT scan, you see that the probability is a plus minus more or less 10 millimeter diameter in the tibia. Have you ever gone from the lateral side from the tibia just to be sure that your fixation points is okay? Because I have never done this for the revision. I have never done this. But this is, I want to learn from you, people like
actually, you can redirect your tibial tunnel as well, make it more vertical. Start from lower down, make it more vertical, and it will only coincide close to the aperture, but farther away, you'll have better bone.
That's a good technique, but at the same time, you try to graft the other hole which you are not utilized.
Yes.
Gopi, have you ever done from the lateral side in your practice ever?
No.
Tibia from the lateral side? I have never done. Kanchanda, have you ever done on the lateral side?
I always used to do my PCL from the lateral side before, but now it's changed.
Okay. So I think
can I make one comment?
Yes, always there will be pause from your comment. You don't have permission.
No. So I think this is a comment for youngsters for a second surgery in general, and particularly when the failure in ACL is graft failure. You have ruled out everything else. It is the graft failure, which means you have to put another graft in the right position. My advice is do not compromise. So we have this tendency because of patient's pressure and our own, we want to do one time. Why do 2 sitting? Patient also pushes you to do into 1 sitting, and you get pushed into it. And you read up so much that you can do this way, that way, little here, little there, and you can do 1 stage. As a surgeon, as well as a patient, you are pushed into doing 1 stage surgery. I think that's a very, very wrong approach. Be very careful, caution yourself, ever in doubt. And mostly you should be actually in doubt. This is the second surgery, you cannot afford to have a failure. So it's better to do it in 2 stages whenever you have even slightest doubt. And you'll be surprised how often the patient after first surgery, where you have only put graft, you have done no ACL reconstruction, you have done some meniscus, trimming, etc. And patient comes back to you for no second surgery, doesn't want a second surgery because he's fine. And this has happened so many times. So I think rather than going and putting a body graft again, we don't have allograft here. He has some counted grafts there, and you cannot compromise it on your second surgery in general in life, and also very specifically for a graft failure which has happened because of ACL failure. You have to have a very, very, very potent soil for your next graft. And if you're doubtful about that, avoid the temptation of going in and doing it in 1 stage. Thank you.
We are lucky that in this forum we have got three real great faculty over here: Jiten sir, Kanchan sir, and Gopinath sir. The thing is that I whenever I do the revision ACL, I have got one problem. Still, I have not solved that problem. You have to solve that. The thing is that when I graft on the femoral tunnel, I always struggle, and my juniors, those who are assisting, they enjoy my situation because they rarely see me struggling doing some scopic surgery. So they really enjoy and laugh at me. So how to prevent, how to do it easily at the grafting at the femoral tunnel. Gopi, you have shown me one beautiful trick, but I will ask to Jiten sir first, then Kanchan sir. Jiten sir, how you go put the graft in the femoral tunnel?
Yeah, so you can have an idea about the approximate graft size, like with a probe, approximately how big is the tunnel. Now there are 2 ways. One, you can take a cancellous bone, as Gopi has shown very well. I prefer a osteochondral graft or a corticocancellous graft from iliac crest, which I just hammer it. It's a good graft, approximately the size of the tunnel, rather than putting a cancellous graft, which can sometimes displace, sometimes may take time. I impact basically, not a cancellous bone, but a corticocancellous graft, approximately the size of the tunnel. Take it at the mouth and with some punch, just hammer it in. It just sits there very nicely. It more or less takes almost immediately. You can say it is a compression fixation of the graft. That's what I like. If it is even a moderately bigger size. If it is a very small tunnel, then of course this cancellous bone plug is good enough.
Then the problems are these different. Problem is that I know that it have to be corticocancellous, but the exact trajectory to get from the portals and put it inside, that becomes the problem. Kanchanda, your opinion on that?
You're saying
how to get the trajectory of putting that graft inside, because that
what,
is always
are you talking about the bone graft, or are you talking about the ACL graft?
Bone graft, obviously bone graft. Bone graft.
Never a problem for me. Never a problem for me. But I can tell you there's one easy way, and I've learned it from Bhasin. And that is take a disposable syringe, which is pretty large, and aim it from your accessory portal, and you can see it going up to the tunnel, and then that directs it. It does not move at all. I learned it from Bhasin many years ago.
Yeah, that's a good technique. You can almost see the trajectory, and
yes.
You can hammer it.
Yes.
Understood. That is a good technique. Yeah. Because I think Gopi has already told us one technique, because he was probably guiding with one suture. Gopi, you are guiding that graft with the suture?
No suture is used, because most of the time patients are not really willing for a huge corticocancellous graft here. So allograft is available to us, femoral head is available to us. We have funnels of different sizes, but you put the funnel into the defect, and then the same funnel can be used to make the graft as well. You just hammer it over the femoral head, you get a tube-like graft. Different sizes are available. From the one femoral head, you can get 3-4 grafts, 3-4 sizes. So you can decide which can.
Okay.
Other one you can discard. So when you use allograft from femoral hair, discard the graft which is not fitting into the defect, and then you can make a new graft. So that like that we are planning.
You are getting your allografts at your state, or how you procure your allograft over there in Kerala?
We usually get from Ramaya Medical College. It is 10,000 rupees they charge for one femoral head.
Okay.
Overnight, the patient will.
You get from Ramaya. Okay.
Ramaya.
So
We get from Ramaya.
I think if Arnab, is there any question on the chat box or in the YouTube channel, or else we will move to Kanchan sir's lecture?
One question regarding the patients who have got failed ACL
Yes, Vikram has got a problem. Vikram will come down to you. Okay, Arnab.
due to ligament laxity. So if a patient comes to you with a failed ACL and you find out that the patient has got a laxity syndrome, how to go ahead?
Better to counsel because ligament laxity, because if the primary ACL surgery, the second surgery is also going to fail, because the primary ACL surgery in the Brighton 5+ is also always a problem. Your graft should be like bone tendon bone. So many things we have discussed in the primary ACL. In the secondary surgery, again, this is a problem. And we have to probably add on what Kanchan sir is going to tell on us. Okay, Kanchan sir?
Yeah,
that's
I think we'll add on. I'll touch on that.
Add on, because we'll be listening to Kanchan sir's lecture, then probably this answer will be a bit answered. Okay. I think Vikram was waiting with some question. Vikram, can you go ahead? Unmute yourself. Vikram, please unmute yourself.
Yeah. So to the question with regards to, having a mismatch between the instrumentation passing the graft into the tunnel, a good idea is to actually view the tunnel from a high anteromedial portal and use a low portal while you're passing your instrument past the graft. So when you see the tunnel end off, it becomes a lot easier to pass the graft in the direction of its course.
Vikram, the problem is not seeing the tunnel and passing the graft. Problem is the trajectory of putting it with a tamp. Always there is a fear, always, because the way the fear is that suppose you want to put a 2 centimeter or 2.5 centimeter graft inside the tunnel, always there is a fear that when you tamp it, probably there might be an inadvertent fracture of that graft. Then you are in real problem and real shoot, because you don't have too many options with the graft every time and go and take another graft. So that is the problem. Probably, I think Kanchan said whatever he has told, because I have never tried that what Kanchan said led, because he has hidden this till this webinar. He has never told me. So that's why this is the reason of organizing. He has never told me that this is the technique he is using.
Another piece of this thing here, you have an old oat set that you have used. These oat tamps that they have already have that sleeve attached to them, which you could actually use to, that prevents the graft from going haywire while you're passing it.
But
A little more expensive version of what
we have tried with the oat set. Do you know the maximum size of the oat set? That is problem is the 8 millimeter.
Yeah,
10 millimeter has just come in. 10 millimeter has just come in the market, and it is still available not in every place in India. So the problem is the 8 millimeter graft with the oat set. That is the problem. Okay. So this is the syringe technique. I think that is the Atmanirbhar Indian type. Whatever we are doing now is with the Indian Arthroscopy Society. So that will next time onwards, if I get that, I will do that. I think. Oh, I think we can move ahead with this lecture now.
Yes.
Arnab, can you unmute everybody except you and Kanchan sir?
There is one question from Gigi sir itself to Gopinath sir. That is there any role of 3D printing in planning for revision?
Yes, definitely. If you have option of a 3D printing, it is really excellent. You will know, as in acetabular fractures, when you do, if you have a 3D printing and a 3D model in your hand, then it's quite easy for you to do an acetabular fracture fixation. And similarly, in a revision ACL, if you have a 3D model and 3D printing, you will know the direction of the tunnel, you will know the defect size, everything. You have that, it's a great thing.
Thank you.
Okay.
Yes, sir.
So, Arnab, please mute everybody.
Yes.
And unmute Kanchan sir and you only. Okay.
Yes, Kanchan sir.
So you can see my screen.
So not now.
Can you see my screen?
No. It is totally black. Totally black. So come on with the first slide, please.
I am there with the first slide.
Yeah. Now it is there. Now it is there, Kanchan.
There. Okay. Now
it is again black.
Again black.
Okay.
So you double click on the first slide, make it a big one because full
No,
screen.
it's still not coming there.
No, it will come. It is
Sir,
coming.
you
It is
start
coming.
screen
It is
share and
coming
you
on the
select
screen.
your screen, not the PPT. You start screen share now and select your PPT. So on the share screen option, you click
Yeah, I did.
and select your screen, my screen, not the PPT. Then it will be shown. Click on the share screen.
Yeah,
In
it shows share screen.
in Zoom, sir, click on the share screen, then select your screen. Then you start. I think that will solve.
Another one thing when Kanchanda is coming around with his talk is that when you do, this is for the juniors, when you do your primary SLs, please never compromise with your tunnels because you know what is the difficulty in doing the revision because these are all young people where if the first surgery is wrong, it is not only ACL. If the first surgery is wrong, then who is going to do, even if you are doing the second surgery, you will be in real trouble. So try to make the first surgery because it has been already written in everywhere. The surgeon who is getting the first chance, he is getting the biggest opportunity.
Can you see anything there?
Yeah,
Yes,
yeah, it is there. It is
I
there.
think let's go with this because
Okay,
the moment I'm getting the whole screen on, we are having some difficulty.
Can you move ahead? You just double click on the first side, probably then only it will move.
No, it's moving, but the moment I get the whole screen, it goes black. It's
Okay. So
going,
no problem, no problem. Go
it's
ahead
going
with
black now. It's going black now.
black again, black. So I think
So
go ahead with older one.
I think
Yeah.
I'll go with this. I'll
Yes,
go with this.
No problem, no problem.
All right. So we know that what is failed ACL, like we've heard so many times, it could be instability, it could be stiffness, and it will be pain. And each one of them will have to be dealt with differently, like Jiten has just mentioned. Make sure that just because it's some kind of a failure or some kind of issue where it makes the patient unhappy, it does not really mean that you have to jump in and operate all over again. In the vast majority of cases, you have to be very, very careful about going in the second time around. For all of us, it's a little easier when we have our own cases coming back to us as unhappy patients. Then we take it a little longer to decide to go for a second surgery. It's always a lot easier when somebody else's surgery comes here and we want to jump in again to do a surgery. So think of every surgery, every case that comes to you with some kind of a failure, some kind of an unhappy camper. Just imagine that you've done this surgery. You could have done it too. That the Mars report says that the failure could be because of a surgical error. It could be because of a trauma, which is the renewed injury, and it could be a failure of graft incorporation. In the early parts, like about 10, 15 years ago, the vast majority of the failures were technical failures, and a lot of studies have shown that the commonest cause of failure has been anterior placement of the graft in the femur. Things have changed a little now, but regardless of whatever you think, it has not changed a whole lot. It has been seen that when you look at the large number of ACL surgeries that are being done, 80% of the surgeons who do the ACL reconstruction do less than 20 surgeries a year, which is less than 2 surgeries a month. And their failures are going to be a little bit more. And that is the overall case of failures. And that is why we have such a large percentage saying that the ACL can fail from anything from 6 to 7% to going up to 25%. So it takes all comers. In some hands, it feels a little bit more, in some, it feels a little bit less. And that's only the technical part of it. But there are other issues involved. See, when there's a surgical error technique and everything else remaining same, and after the proper prehab, after properly evaluating the patient and understanding what he wants to do about it, the surgery probably can become a little easier by doing a revision surgery. Again, always telling the patient that the results of a revision ACL is never, ever going to be as good as the primary ACL reconstruction. And this is something that has to be overemphasized time and time again. The important thing that happened is that over the years, this is how things change once we go from one stage to the other stage. Once we've come to the intra-articular ACL reconstruction, we are thinking of different kinds of putting the ACL graft, different kinds of ways of fixing it, different soft tissues to use as grafts. And we forgot that the instability may not be only because of the ACL injury. We may have missed the MCL, which happens in about 2% of cases. I mean, we may have missed it more, but in 2% of cases that cause symptomatic instability. We may have missed the PLC, and that's a pretty large number, but the most dreaded one is if you miss the PCL. And we've all seen a torn PCL comes to somebody and is reconstruct the ACL. The torn PCL has remained the way it was. In a way, if it's just a torn PCL, probably handling it would be a little better than everything else, because you'll have to go back, do the PCL, maybe do the ACL again also. But is the PLC, that's something that we have learned over the years and learned to, and this is something that we have learned to our detriment. It's something we forgot that could have happened. It could always have happened before. So always look for things like a detective, like Gigi has mentioned. Do not miss the lateral and posterolateral insufficiency. So try and do all the tests that you can, because trust me, you cannot always read the lateral and the posterolateral soft tissue structures in an MRI. At least I cannot. So I'm better at evaluating these clinically. And once I have something in my mind, I can put it into the MRI, and then sometimes it works. And sometimes it does not, and I can take the MRI to my radiologist friend and he can explain it to me. Do not forget to do a dial test. A dial test is not a test only to be done in a PCL injury or a multiligamentous injury. A dial test is also very important when you're examining failed ACL, where you think you might do something, you might need to do something. Check for MCL. The two things about MCL, whether it's opening up or is it just pain. If it's opening up, then you may have to do a reconstruction, just like Gopinath has mentioned. Look at the PCL and see that somebody has not missed the PCL. But PCL, fortunately for all of us in a week, we can read the MRI pretty well about the PCL. So once you have, or once you have seen how it works clinically, and then you can put everything back into your MRI, reading the MRI reports, and then go ahead. The varus thrust is so wonderfully demonstrated by Gopinath previously. And then you have the generalized ligamentous laxity. People with generalized ligamentous laxity have a higher instance of stretching out and failure after surgery. So if a patient comes to you who's already had a generalized ligamentous laxity, you have to be doubly careful, and you have to spend more time in explaining it to him why he is likely to have poorer results. And this is also a situation where you would like to use a stiffer graft, and also you'd like to always use an extra-articular augmentation. And always, always, always play on the expectations. Bring the expectation down to realistic level. That is very, very important. Now, you'll have to bear with me because the animation is not working. I can't get it on the full screen. So sometimes you may not be able to see a few of those slides. Now, this is what happens when you have patients with an ACL surgery. What is the treatment modality? Do you think all of them will need surgery? All of them will not need surgery. Just because there's a failed ACL does not mean that all of them will need surgery. A lot of things have to be explained. A lot of things have to be worked out with them. And a lot of time and effort has to be done on rehabilitating the patient all over, just not the knee, all the core muscles. And you'll be surprised how many of them will do quite well without another surgery. And then when you decide that the surgery is required, when the patient also understands that the surgery is required, and it's also been explained that what it entails to do the surgery, it's your job to decide whether you're going to do it one stage or two stage. As I grow older, I find that I'm doing slightly more numbers of two-stage ACLs than one stage. And this something that has happened over the years. I'm doing more and more additional procedures on ACL revisions, almost always on key athletes, and almost always with patients who have generalized laxity. But by and large, the numbers of additional procedures have increased. There's nothing new about putting in additional procedures. See, in the 70s, Houston had described about the interlateral and rotary instabilities. It was good and bad in one way. Good in one way that we learned to realize what the instability is about. But we took a little step backwards. We went away from the more difficult intra-articular reconstructions to doing a whole lot of extra-articular reconstructions, which did quite well on the table, but they always failed very quickly, and they also had higher instances of osteoarthritis. Among the first ones to be described was the Lemaire's procedure in the late 60s in France. And it's interesting, Lemaire also comes from Lyon. That's where Letager comes from too. So a lot of things have started from there. So Lemaire was a general surgeon, and he used the iliotibial band, passed it beneath the lateral collateral ligaments, and attached it to the soft tissue, and they brought it down again in the region of the lateral gastrocnemius.
Slides are not moving. Kanchana, you are still on the first slide, or you are just moving the slides?
I'm moving the slides. They're not moving?
It is not still on the first slide.
Now?
Which slide you are? No. It is not moving.
Select your slide on the left screen. You select one slide.
Yeah.
You click on that.
Yes.
No, click on the slides. Number 1 was blue. So you need to click the number 2 or 3. Select.
This is the number 1. This is the one that you're seeing.
Yes.
Yeah. Still now we are on the first slide.
Are you seeing anything now?
No, it's totally black.
Whoa.
You can show. You can see.
You just go ahead with the slides from your arrows. I think Kanchana, just try once. Arrows from the keyboard.
Down arrow.
Now?
No, it's not moving. Or else you select the slide from your mouse.
On the left side, you select the slide. Yeah. Number 2 is visible now.
So go to number 3, please, once.
Click on number 3.
Yes.
Double click on that.
Yes.
Now?
No, sir.
No, it's not moving.
It's again the first one?
So Kanchan, can you try the left extreme corner view?
Left extreme corner.
Left extreme corner view. Left extreme corner up.
Just at the red dot. Just on the left extreme red dot is there on the left side. Go to the left of yours.
You are in the middle. Yes. View. Press the view. No, low down view. Yeah. Press this.
Yeah.
What does it say? It doesn't say anything.
Navigator. Then slide only. Now, can you see anything?
No. We can just see the second slide. Just press the view.
All right. You can see the second slide.
Yeah, but it's not moving to third.
All right. So, and now?
No, nothing. Now it's gone. Play is not important for you.
All right.
This play option doesn't work.
All right. Then I think
now it is now
we are better.
Now it is better. Now go ahead with your arrows on this keyboard.
Down arrow on the keyboard. Those 4 up and down and left and right.
Not working. The keyboard is not working.
Okay, just close this window. Build order. On the right and down. Right corner down. Right corner down. Close this window. Yeah. Close this window. Can you not close it? What program is this?
Build order. This is Mac.
Oh. So what to do?
Is there a PowerPoint or not?
Is there?
Keynote. It's Keynote.
Keynote causes many problems.
You click on the play. Then
what you can do, Kanchanda, is to reduce the zoom size.
Now you go to Zoom, click on share screen.
Okay, let me go there again.
Yeah, now it is okay, working.
And
what can you see?
Reduce the slide size also. Otherwise, the top part and the bottom part are getting cut off.
Yes.
So to the left upper corner and reduce that 100% to about, say, I think 75-80%.
Yes, yes, from that 100%.
All right. Can you see that now?
Has it become around 80? You have selected
75%.
5%. Okay. Then go on to the next slide. See what happens. Till now, it is same as it was. Till now.
You can only see the first slide.
No. I can see the maybe
See a
third
2%,
slide, but the top that is
like
the line and the title is cut off.
All right. You can see the missed injuries. Is that what you can see?
We can see.
Yeah.
Yes, we can see the missed associated injuries, 15%.
All right. And now it's not going further down. What can you see? Look for
injuries, missed associated injuries, 15%.
Oh, it's still there. Okay.
Is it moving? Is it moving on your screen?
No, I'm moving it from the top. Now is what can you see? Look for, or what can you see?
Missed associated injuries.
Oh, it's still there.
Sir, you close it, then you stop your share.
Okay.
Then you open your keynote.
I'm closing it.
Yeah, you open your keynote. You click on the play. Then you come back to Zoom and start your share.
All right. Open the keynote. Then I open my presentation.
Then go to slide share screen.
You start the play there. Then you come into Zoom and select that window. When you click on share screen, you will see multiple windows. And from those windows, you need to click.
I can see share screen now.
Yes. Then you go to the presentation, where the presentation is. Yeah. Then you share.
That's whiteboard, iPhone, iPad, AirPlay. Is that right? Or is that files?
It will be opening a smaller one.
Any option called My Screen. When you click on your share screen, do you have any option like My Screen?
No, it's can I try the iPhone, iPad thing? Maybe that one.
No, it's not, sir. Your screen. You are doing from a laptop, na, sir?
Yes.
No, so first window will be your screen. When you click on share, first window will be your screen.
Yeah, it's my screen. It shows desktop on one.
Yes. You click on that and you select start share. Yes, now you open your...
Now it will come. Now
Now we can see your desktop now.
Yes, now you open your...
Now go to the PowerPoint, which yes. Go to the PowerPoint.
That's okay. Keynote is okay.
Yes.
Anything?
Yeah, this is visible now. Extra-articular procedures and division.
Now?
Now it is perfect. Now go ahead with the slide where you left.
All right.
I think you go to the 7th slide. You are going to the Lamar.
Yeah.
Number 7 slide.
Yeah.
Yes, this one. Yeah.
This is the one? All right.
Yeah.
So Lamar described his procedure in mid-60s, 67 or thereabout, and he used iliotibial band, which he released from the top and it was attached distally at the Gerdy's tubercle, rerouted it beneath the lateral collateral ligament and fixed it laterally at the region of the attachment of the lateral gastrocnemius and turned it around. McIntosh did it a little later. And again, it was nearly the same thing. Again, it was passed beneath the lateral collateral ligament, brought onto itself and sutured to the near the Gerdy's tubercle. So they're pretty much similar, and they were all designed to prevent the interlateral instability. And this is another picture of McIntosh's surgery. These are the surgeries that we had seen during our earlier stages. Our teachers were doing them, a wide variety of them. And all these pictures have been taken from Philip Landau's studies, Philip Landau's publication a few years ago. And this was yet another, which is a losses procedure. One of our senior teachers, Kullan Mukherjee, used to do it quite a lot with pretty good results, actually. And again, short-term good results. But when you look at all of these, and the Ellison's procedure is the only one where you leave it attached proximally, you take the distal part with a flake of bone, and then reroute it beneath the LCL, come forward, and then attach it to the place where you took it from or slightly more medially. And they all tightened the lateral part. And then Jimmy Andrews designed this procedure where he would make a slit at the lateral, the iliotibial band, tighten them together, make two holes, and then tenodese it. He had modified it a little bit later. But when you look at all of them, they're pretty much similar. The modification of Lemaire's procedure that has become popular for the last about 15 odd years is taking the same strip of iliotibial band about 1 to 1.5 millimeter wide, about 80 centimeters long, carefully releasing it from the muscles beneath, carefully not injuring the capsule of the knee joint, and seeing that you got a full length strip, and then whip stitch it, bring it deep to the LCL, and attach it proximal and posterior to the lateral epicondyle. When you make a tunnel in the lateral epicondyle to fix it, which you can fix either with a tenodesis screw or an interference screw, make sure that since they're always with the ACL, make sure that you make your tunnel, which is directed anteriorly, or you might damage the original ACL tunnel. So I tend to do this more and more. This is a diagrammatic picture, and the other one that shows how it's being done. But these are none of my own pictures. They're all in the hospital, which is closed now. So, but this is something that I keep doing more and more often nowadays, and I find that over the years it's become more and more reproducible, and even the scar on the lateral side has tended to become smaller and smaller. But one thing has happened is that quite often I have a hematoma, and I know that it's because the genicular vessel has been damaged. So now the thing that I've learned is I always take the tourniquet out before I close everything here and see if there's any bleeding there, take care of this, and then close. Around 2003, Claes described the lateral ALL. Now, this is not a new thing. Actually, if you look at Seagond, he described this way back in around 1890s, where this is attached with a condensation of the iliotibial band that attaches on the lateral part, just lateral to the Gerdy's tubercle. And Claes, in 2003, described it. It made a lot of furor. It was described as, he was awarded as the best paper award, and then people tried to bunk it. But it seems to have gained a lot of traction. A lot of surgeons swear by it in Europe and in UK, and they always add ALL to patients who are young, who have an explosive pivot shift, and patients who have some element of generalized laxity, and women. They seem to have good results with this, and I've tried this in the earlier stages, and I also have had good results with it. But whether you want to add this to whatever you're doing remains to be seen. It's very important that when you're doing a revision surgery, whether first stage or second stage, the most important thing is that you do the intra-articular procedure perfectly well. You fail in the intra-articular procedure, your extra-articular procedures are not going to bail you out. The primary job has to be done properly, and you need some additional harnesses to help you. The reason why people have started to go forward to do extra-articular procedures is because they have now had literature to back them. A 2-year outcome published in 2000 is in primary surgeries, they've done a randomized controlled trial in patients who are young, who have grade 2 pivot shift, and who are supposed to be high-risk patients in terms of athletic activities they are involved in, and generalized laxity, broken into 2 parts. Some of them have had, half of them have had LET, half of them had only ACL reconstruction. And they found that the ones that have had ACLR with LET have been significantly better in terms of lower amount of laxity and lower amount of rupture than those who did not have it. So this made people think that probably it would be a good idea. And then when you look back at literature, in small to midterm studies of anything from 3 to 19 years, it has been radiologically and clinically proven that ACL with LET has been given good continued improvement in clinical radiological outcomes. Those who have had meniscectomy have had poor outcomes. The other study by Colombet shows that for a person who's had a torn primary ACL, if you do an ACL revision, his IKDC improves. If you add an LET with it, it becomes more stable. It improves stability in both AP and rotation stability. However, not much change in IKDC scores. So you have two of them, whether you want to do ALL or LET. There are some biomechanical studies that day zero, the LET is significantly stronger in preventing both anterior translation and rotary instability than the ALL. And that is one of the reasons why most people are doing LET rather than ALL. Now, even when the study by Andrew, they have tried all different forms of lateral extraarticular tenodesis and ALL. ALL is ALL, of course. Lateral extraarticular, they have tried Lemaire, McIntosh, both passing superficial to the lateral collateral ligament and deep to the lateral collateral ligament. And they found that going deep to the lateral collateral ligament is the one, whether you do a Lemaire or you do a McIntosh, the one that gives you the best form of stability. So probably this is, you have ligament backing you to do this. And augmentation, this is the interesting study where people are, where there's the study, it's a computer navigated study. And in revision ACL, the ACL is reconstructed to look for pivot shift after the surgery. And if it's more than 2 or 3, an ITB tenodesis is performed, and apparently does well. But this is something I find a little too far. But this is one of the best studies. We've seen Markakci in Bombay a couple of years back. He's been doing it from the late 80s. A hamstring over the top, bringing it down, and it's an intra-articular, extra-articular procedure that has been doing it for. His initial study was for 13 years. Zafagdin has published a follow-up of 20 years for all high-end athletes, and 3% failure. 11-year good, sorry, 10% failure, overall failure, but graft rupture of less than 3% in all those years, all high-end athletes. And in Italy, there are a few other techniques that are being followed, but by and large, a large number of the surgeons use both the intra-articular and extra-articular for almost all ACLs. And that probably tells us that this has something you need to talk about. So what's the take-home message? Not all ACL revisions are the same. You have to treat all of them differently. Some will not need surgery. Some will always have to be 2-stage. Or even after 2-stage, you have to decide whether you want to do surgery or not. Always look for something that you probably may have missed earlier. So if there are other insufficiencies, they must always be addressed. For the extra-articular procedures, LET works well in most cases in addition to ACLR, but always, always get the intra-articular reconstruction right. The others will only help you. They will not bail you out. Like I mentioned, over the years, I seem to be doing more and more 2-stage surgery and more at adding an LET to my ACL. Thank you very much. And I'm so sorry to make you suffer through my technological drawbacks. Thank you very much.
No, Kanchan, we have got the idea when to add and how to do it. So always we are with some problem with this is because not been done previously only because of the pandemic, probably using this sort of virtual meetings, we are always in a hitch. So the main idea is to give the message. So any question, Jiten sir, anything to add on?
Very, very nice words of wisdom from Kanchan. All 4 take-home messages were perfect. I think there's nothing I can add to this. Okay, so if there is no question, Professor Gopinath, do you want to add on anything on that, or else we will move to Vikram's cases? Gopinath, you are muted. Can you unmute yourself? In the meantime,
that is a perfect presentation, and In the extra procedure, I think we should talk about the postlateral corner injuries like leopard or Larsen and the medial side. So all amounts to extraarticular tissue reconstructions along with ACL.
Absolutely.
So,
You mentioned them. You already mentioned them.
Yeah, that's correct.
Okay, so I think if there is no question in the either in the chat box or in the YouTube, Arnab, is there any question so that we can answer, because otherwise we'll move to the cases.
Yeah, I think we can go to the cases.
Okay, I think Kanchan sir, you please unshare your screen, or then we'll Dr. Vikram will be sharing his screen. So I think the message is not only for the revision, also for the, even if you drew your grade 3 pivot in a young guy, and if he is a young guy, probably sometimes you have to add on the LETs. So Kanchan,
Yes.
because if he is a young guy, pivoting and cutting action is needed. Even grade 3 pivot, you must do, just don't miss out any root injuries. And sometimes if the root is not there, then probably you have to sometimes add on the, even for the first time, you have to add with the LETs. Is it true now, Kanchan, these ideas?
Yes.
Yes. So I think if that is the message is gone there. So Dr. Vikram, can you make it the full screen now? Yeah. So I think
thank you so much, Team Calcutta, Dr. Kanchan, Dr. Swarnendu, Dr. Karmakar, for this wonderful opportunity. It's really an honor to be in the presence of such eminent faculty. To start with, what we should remember, as the seniors have said, that ACL revision surgery is an epidemic now, thanks to the number of ACLs that have been happening all over our country. And we need to gear up in the future for more such cases to come into our primary practice. While tackling these cases, we should remember that it's not only a stress for the patient, but a stress for the surgeon to deliver to. So there are typically 3 factors that I look at before I approach a patient with a revision ACL. Number 1, is there any technical glitch done in the previous operation? As in wrong tunnel positions, missed some ligamentous injury that was associated with it? Number 2, is there anything anatomical in this patient that could predispose him to a failure? Something to do with slope, to do with overall alignment? And number 3, which is of paramount importance in the population we deal with, is the psychosocial connotation that a revision operation has on his mind otherwise. So it's very important to meet patients' expectations. So on that note, let me begin with my first case. So here we have a 35-year-old dentist with a history of an ACL reconstruction with a medial meniscectomy done a year and a half ago by another colleague of mine. He came to me with symptoms of the knee giving way only when he plays soccer. And this was for the past 6 months since his primary surgeon asked him to get back to full activity levels. He also presented with the occasional lock when he was playing soccer. Kind of obese, about 31.1 BMI. So he was more or less, let's say, a weekend warrior who liked playing soccer. This was his clinical assessment. So on an anterior drawer, was unstable, about a grade 2 on the anterior drawer test. This was his MRI. And the arrows, as you can see, indicate a graft rupture as well as a bucket handle tear of the medial meniscus. Clinically, there was no other ligamentous injury that I could appreciate in view of a posterolateral corner or a valgus stress test for the medial collateral ligament. So what do we do next? So what I did was, first, I got a long leg lateral view to check the slope of the patient. And I used the Napier method to check the slope. And the slope was about 8 degrees in this patient. This graft, mind you, was fixed with a metal screw distally and an endo button on top, on the femur. I also got a long leg scanogram, and that revealed almost perfect alignment on both sides. I did get a 3D reconstruction, CT, which I do for most of my revision cases, of the notch. And this is what it revealed. This was the tunnel position on the femur as well as the tibia. And as Dr. Samanta said, more often than not, tibia, we kind of err on the side of being right. Femur is a big controversy. As Dr. Kanchan very beautifully pointed out, we have over the top position to putting the tunnel in various locations on the lateral wall. But what is right? So if it's not worked for the patient, then it's wrong. Let's put it that way. So what next? Any inputs from our esteemed panel?
Yes, I think Vikram, whenever you go with your revision ACLs, you have rightly told that it has to be a long film. Otherwise, if you have because if you are on the your limb alignment is not being checked mostly in the primary ACL, then you get a problem. Second thing, probably in the film that we have to check is the tibial slope. Sometimes even the tibial slope is, if it is more than 12 degree, then even if you do a revision ACL, still it is going to fail. So 12 degree tibial slope is the cutoff of your tibial slopes. So every time you see that your primary ACL is failed, not only just go on and jump on doing the second ACL surgery. Sometimes even if you do a corrective osteotomy with slope correction, and then probably the patient might be so happy, he may not turn out with your second surgery because that might be the primary one. And second thing is, as Kanchan sir and everybody is telling, like, you don't miss out with your peripheral injuries. That has to be mandatory. And now with this 3D picture, whatever is there now, probably the femoral tunnel is very low. That is the anterior. So on the femoral side, probably you can have a new tunnel. The femur is not going to bother you for this case. And the tibial tunnel is, as I told, mostly that if the tunnel is more or less in between the two spines, so tibial tunnel is always a problem. So that you have to recreate either from the medial low one, as Kanchanda told, you can completely make a new tunnel, or else some people are going around from the lateral one, but I have never tried from the lateral side of the tibia.
There's one
So
one
what
other
did I
thing.
do? So I counsel this gentleman. Yes, sir.
Yeah, you have a bucket tendon tear of the medial meniscus, so that's a very strong restraint. And in this case, you talk to him properly. If you can repair the medial meniscus, it'll add a lot to his stability, in addition to the ACL reconstruction that you're going to do.
What kind of meniscectomy has been done in the first place?
No, he has a bucket tendon tear now.
No, he primary had the meniscectomy that time.
Oh, he had a meniscectomy already, so he doesn't have a meniscus anymore.
No, he does have a meniscus. So that's the catch. So he had a meniscectomy done by another surgeon. So this was an other person's case. And you can see a beautiful displaced fragment, as Dr. Kanchan rightly pointed out, on the MRI. So there was a re-bucket handle tear, right? Right, absolutely.
Yes.
So thank you, sir. So can I proceed?
Yes, proceed.
Okay. So what I did was I sat down with this patient, and firstly, I needed to demystify the fact that he had a meniscus done earlier. So how did this meniscus come into the joint? And number two, him being educated and one of our own colleagues as a doctor, I had to also explain to him what would be the micro of action later on. And considering, as Dr. Samanta very rightly put, this tunnel should not interfere with my next step of doing an ACL reconstruction. But nevertheless, I'm usually circumspect in these kind of cases because our Indian population, their notches are relatively smaller in size. And you cannot say what effect the graft has had on the diameter of the tunnel that you've drilled inside. So I did tell him that my intention would be to do a primary ACL, revision ACL reconstruction with a lateral extraarticular tenodesis, and do this thing later on, or do a two-step ACL reconstruction. Now, this is exactly where the tunnel should be, as Dr. Samanta pointed out. So this, the new circle that comes there, I felt this will not interfere. If, by the way, Dr. Kanchan said, if we change the trajectory, I should be able to avoid this. So what would you do? As rightly said, we said either a single stage ACL plus LET, two-stage revision ACL plus minus LET, or a single stage revision plus lateral extraarticular tenodesis. So this is what the video of the patient was. So the moment I put my scope inside, you can see a part of the periphery, again bucket handled into the joint. So the meniscectomy was not complete. It's very important to identify tears beyond what you remove. The ACL graft was almost non-existent on the wall. So my first step in a stage 1 is to curate the tunnel to feel the quality of the bone. Now I'm looking and working from the lateral side so that I get an end-on view of the tunnel. I mean, on the medial side, I'm working and viewing from the medial side. After I freshened it, you can see good bleeding that has happened here. And then using this stamp, I have grafted this tunnel with a mosselized, compressed, cancellous graft that I obtained from the tibia below. So this is, as you can see, it's covered the whole tunnel nicely, but viewing and working from the medial side helps. This was a tibial tunnel that I had, and I, of course, grafted that too and removed the screw as a consequence. The bone graft incorporated over the next few months. So what happened to this guy? A very motivated patient who was ready to go the full way for an ACL reconstruction, he decided to give up sport. He was happy running and jogging, and 3 years counting to undergo stage 2. So basically, he chickened out of going through a stage 2. So this gives us an idea of the gravity of this operation and what kind of connotations it can have on the mind of a patient. So what were the lessons learned from this case? CT is important to analyze carefully. So my next slide will show you that the size of the graft used earlier and the width of the lateral wall of the notch is very, very important when you're deciding on doing a single stage revision ACL. Because if the graft is very large, your tunnels are large, with a relatively small notch, you will more often than not have to err on doing a 2-stage reconstruction. So as Dr. Maheshwari rightly pointed out, better to be safe than sorry. And revision surgery, especially in 2 stages, we need to remember, takes its toll on the patient, and he compromises at times with his ultimate result. So this was what I thought was my tunnel, but this is what I ultimately found, because the tunnel is never circular. It's usually elliptical because of the direction in which you drill. Number 2, you do not know when you're inheriting a case from somebody else, the number of attempts he's possibly made to drill this tunnel. So when I read my CT scan 3D, I realized that this whole footprint was actually part of the tunnel ultimately and not an absolutely circular tunnel. Can we move to case 2? Any comments?
Yeah, I would like to make a comment, Vikram. Again,
Yeah, sure.
I think most of the comment from me and Kanchan is going to be more philosophical. And one philosophy I've learned over the years is you will read this literature and say, we did this surgery and patient never came for the second surgery. Now that's a very good phenomena where you do one surgery on the patient, find some reason, which may not be the main reason, which may be the side reason, but more often than not, patients become all right. So when you divide your surgery into 2, particularly if the whole surgery is going to be big surgery, ACL reconstruction with extra-articular, with this, with that, and you are beginner, it's a good idea to do just one surgery first, buccal tear removal, and you'll be quite surprised that more than 50% of your patients will manage to be happy. They may not be happy, they'll manage to be happy. They are quite okay with whatever has happened. So that's a lesson I've learned. Don't go too fast, don't do too much. Just find out the basic reason, what you can fix, especially as a beginner, and you may be surprised that patient will be all right. And it's always a good idea to go second time, no problem. Thank you.
All right, so we move to case 2. So here we have a 27-year-old actress with a history of a previous ACL surgery done by me 7 years ago and was doing quite well. She was very happy, back to dancing and doing what she does as an actress, and never had any complaint. She came back to me 1 year following a history of a twisting injury while boarding a Mumbai local train. So while she was boarding the train, she had a proper significant trauma to the knee, which kept her out of action for about 2-3 weeks, but she decided to get back to work and ignore this particular problem. When she, of course, this is an operation theater setting before I started, but I thought it is pertinent that I put this first for you to get an idea of the kind of instability that this patient had. So you can see here, this was a grade 3 anti-draw test with a soft endpoint. And the patient had quite an explosive pivot shift test. The other ligaments were quite intact. So this was an MRI that I did following this. When she came to me 1 year following her re-trauma, and you can see a complete ACL tear in the image here, as well as a peripheral tear of the meniscus, okay, in the sagittal section as pointed out in the arrow below. The coronal section did not give us any extra information, but the meniscus looked reasonably okay in the coronal section, not as bad as it did look in the sagittal section. Of course, I did her slope, and this was about 7 degrees here, but in a re-trauma case, patient doing well. Nevertheless, to complete my investigation, the slope was important. Of course, it was one of my own, so I did do a 3D CT scan. Didn't want to have the bravado that might appear. Though not ideal, it was in a relatively okay position and could interfere with my second stage ACL. That was my thought process. So I counseled this patient that in all probability, she may need a 2-stage revision ACL reconstruction. In the first stage, I'd possibly repair her meniscus and graft the tunnels, give her a gap of about 3 months to 6 months, and then complete immobilization, not immobilization, complete restriction of activities such that she doesn't need to go back to dancing and stuff, but she can lead reasonably sedentary lifestyle. And then I would come back later on and do a revision ACL. So this is what I found. So when I went in, there was a meniscus tear. When you see probing, superiorly, there was an attempt to heal. Inferiorly, there was a tear of the meniscotibial junction. That's why the meniscus was translating into the joint. Of course, I did my regular protocol, rasped it, shaved the part to prepare an excellent bed for a repair. And lo and behold, I went posteromedially, and this is what I find. A classical ramp lesion, as I had seen on the MRI in the sagittal section. So it was pertinent looking at the explosive pivot that it could be because of this. So I went ahead in this patient, debrided. So it looks a lot larger than what it actually is. So if you see, it's much larger than what you actually saw. The capsulo-menisco-capsular separation, as you can see here, I went ahead and using shoulder techniques, repaired this ramp lesion using a suture lasso and PDS, because this area heals pretty well. So I use PDS absorbable sutures here because it's a very peripheral tear of the meniscocapsular junction. Put a few sutures, and this is what I got at the end of it. The rent was completely closed. Of course, I repaired the meniscotibial part of it. And you can see that the meniscus sat down nicely. When I went into the notch, this is what I had to find. There was not much, there were very few elements of the graft that I could see. I used my my bone awl to feel the tunnel, and then my curette to curette it. And I felt there was bone all around. So I decided to use a bead pin and then drill it with a 4.5 to actually see whether this tunnel has been filled up by bone or no. And lo and behold, this is what I saw. So you can see this complete formation of bone all around this tunnel. I wanted to be extra cautious. So I used my depth gauge to check whether this tunnel is actually okay or no. And it was. So I went ahead and did a primary revision ACL reconstruction with an internal bracing and a lateral extra-articular tenodesis, which is a part, a Lemaire modified, which is a part of my protocol for all my revision ACL reconstructions. This was the immediate post-op. So you can say I was a little biased, but trust me, I used all my power to do the pivot shift test, and on table, it was negative. And this was what she was at the end of 6 months, quite happy jumping on one leg and quite happy to get back acting. She was a sporting person and pretty happy at the end of it. So what were the lessons learned from this case? In re-rupture, post-injury, especially in those neglected for some time, suspect additional lesions like a meniscal region or a ramp, because the medial meniscus is a secondary stabilizer of the knee. And when your ACL is not working, it tries to fit in, but can't do the job completely and gives way. Sometimes one may be lucky to have bone ingrowth into the tunnel and a single stage may be possible. Though I'm not a strong proponent, always be ready. The arthroscopy has a tendency to reveal a lot of things, a lot of devils or a lot of gifts, which you may not anticipate otherwise with whatever planning you do in these cases. Any inputs from the faculty?
Very nicely done.
Very nicely done.
Gopinath sir, any remarks?
This was very nicely done, boss.
So has any of the faculty seen this phenomena of graft failure and the tunnel filled up with bone?
Not really.
Not really common. That means the ligament may have ruptured long back. Now this is a very interesting point, that sometime when the patient comes to you, the ligament may have actually ruptured long back and the patient is still managing. What precipitated the patient to come back to you was actually the meniscus tear. Now this very often happens when you go in a so-called patient says, I had injury 1 month back, and you go in, you find no ligament there. Everything is as if it was like 3-4 years back it was torn. So what precipitated in this case, everything was actually the additional meniscus injury. Though when you repair that meniscus, it becomes obligatory to also stabilize the knee. You can't just not do that. But this is something which we learned, that sometimes if you want to be conservative, patient is low key, she's not a dancer, you can just maybe debride the meniscus, make a meniscus stable. I'm not saying fix it and not stabilize the knee, but sometimes a minimalistic surgery in a low key patient can give you a equally good result.
All right. Any other comments, or can I move to case number 3?
I think we can move. Next.
Okay. Right. So case 3. So this was a high demand patient, a 25-year-old soccer player with a history of an ACL reconstruction done on the affected limb, using hamstrings 4 years back. Came to me with a locked knee while playing soccer. So this chap went back to playing, but he said, I never felt stable on this knee. So he was not happy with this knee, but was kind of persisting. He was not playing in the 11, but he was practicing with the team, could never achieve his pre-injury status of playing, but continued doing so. This was his MRI of a bucket handle medial meniscus tear, as you can see here, which is moved into the joint, as well as you can see a semblance of a graft which is there in the notch. So when I went in clinically, he was unstable, okay, in an AP as well as a pivoting test. So what I did was I counseled him to undergo either a single or a 2-stage ACL reconstruction, as I normally do. And to start with, the arthroscopy showed me this kind of a graft picture. So it was a vertically oriented graft, as you can see. And there was a locked meniscus tear in the knee for which he had come to me. Of course, I did his slope, my usual. It was about 9 degrees, slightly higher than on the normal spectrum. This was his tunnel position. So again, as Dr. Samantha rightly pointed, it seems like I can do a single stage reconstruction because I would have normally quite a decent bone bridge between this and I think it would be possible, and the likelihood of me doing a single stage would be higher in this case. So that is what I told this patient, and I decided to go ahead and I did a single stage remnant preserving. So I did not remove this because this remnant does give biology, and did a quad tendon. Now this chap had an ACL done on the other knee also, right? And he was a high demand patient, and in all high demand patients, I do a quad tendon graft. So I did a quad tendon graft fixed with an interference screw on the femur as well as the tibia, aperture fixation. So a remnant preservation technique. And this you can see the graft was quite stable on table. This was the meniscus tear, and I did my standard technique of rasping and nicely mobilizing the tear. And I had a very stable meniscus tear on table, was very happy about this particular case. I also did a lateral extra-articular tenodesis, and this photo I put up here because it nicely shows how the graft, I mean your iliotibial band part that you make for your extra-articular Lemaise procedure, which you can see here, the one with sutures here, how beautifully it passes under the LCL while you are tying it over the lateral cortex of the femur under the vastus lateralis muscle belly. So I fix it with an interference screw besides not a staple, because I think it bothers the patient many times. Part 3 is where the story starts. So a good surgery that I felt I had done, and I kind of lifted my collar up and felt my patient's going to go back to sport. So he did very well for 2 years and was back playing professional football. And every time he came back to tell me, he'd tell me that my knee is a lot more stable than it was before. I think I attribute that more to actually the lateral extra-articular tenodesis, because the rotational stability that provides to a very great extent. Then lo and behold, 1 month before he had come to me very happy, and he comes back and says, boss, I had a sudden episode of the knee getting locked while walking off the field. I was out of town, that was me. So the patient decided to see another senior colleague elsewhere. So the senior colleague did an MRI. And this is what he saw. So as you can see, this patient on the MRI seems like his graft has torn. The senior colleague believed that the deep MCL part also torn, and his clinical acumen made him feel that there could be a medial collateral ligament tear, and this needs to be taken care of. And this was me. So the patient had a lot of faith because he's quite happy with his result for 2 years. So he decided to go back to his original doctor with a little less white hair. And this is what he was. So clinically, very stable knee. We could attribute it, maybe there's a meniscus tear, we can't say, but very stable. Lachman and anterior draw test. So what did I do? So I actually sat him down and I told him, boss, see, your knee seems stable to me clinically. I don't see any reason why you are having this. I feel there could be a meniscus tear in your case, which I could see a meniscocapsular separation there. And possibly it could be that your meniscus gave way, the one which I repaired. And that must be the reason. I can't really make out any other secondary ligamentous reason for your failure. So the patient, I think, got convinced by what I said. And I said, what I'll do first is I'll do an arthroscopy. Let's do a diagnostic arthroscopy and I'll take it as it comes. Now, it was a motivated patient. He was ready for even a re-revision ACL reconstruction. Of course, we have to give respect to a colleague's opinion, and more so it has a far-reaching impact on the patient when a senior colleague tells him a particular injury has happened in your knee, and MRIs corroborate what the senior colleague is saying. So the patient himself, however much he trusts you, is circumspect about these cases. So I did an arthroscopy, and lo and behold, this is what I found. So the meniscus I had repaired, though you can see the synovium, which has shown signs of healing, had torn again. So a reasonably well done meniscus had torn again. The ACL was absolutely stable. So you can see the quad tendon graft has really healed back perfectly. You cannot identify the remnant from the graft that you've put back. And I'm probing it and it's not moving at all. So it was absolutely stable. So this could convince the patient that, I of course did a lateral extra-articular tenodesis also with this case. So this convinced the patient that his graft was okay, his MCL was okay. He's doing well 1 year post this particular surgery, and he still thanks me that he didn't undergo that particular procedure with the previous doctor. So lessons learned in this case. So adding a lateral extra-articular tenodesis in the revision setting protects this graft and adds a double security. So many times the playing field is not nascent in a revision setting. We cannot rely completely on our ACL that is inside, because as we know, tunnel positions can be variable. So understanding certain patient-related factors like slope and correcting the pivoting by using the old technique of Lemaire, which is very pertinent in today's times, does add a double security. Biology of the knee is not the same in a revision setting, and healing potential of the meniscus is compromised. So bravado again. I think doing a meniscus repair is the right thing in this case, and I might do it again in all these patients that come with such a peripheral tear. But a caveat needs to be attached to it. This is not a primary ACL tear where everything is for it to heal. This is a revision setting. Biology may be different. The expectations of the patient are different. This patient was not a patient. He was a professional football player, and his main money and everything came with playing football. Such patients have a propensity to tear their meniscus again because the healing scar may not be as strong as the original meniscocapsular junction that you're born with. And patients should be counseled about the fallacies of an MRI, especially in a post-op setting. So my next slide basically shows this. Luckily, it was done in my own center, so I could actually go to the MRI console and work on this MRI. So this is exactly what the patient saw, and this is what told him or told the surgeon also that the ACL is torn. And our radiologists are very, very busy. They do so many MRIs a day, and when they see the films, they comment on what they see. But very rarely we go ourselves to the MRI center and actually scroll through the images. So I did the same thing by altering the exposure of the MRI. And if you look at the same thing, you can see a semblance of a graft still. What looked like a tear below was actually possibly a scar tissue or whatever ligamentization you may say that you see at 2 years with the with an ACL reconstruction that you saw in the MRI, and the second look arthroscopy proved that. So MRI is a matter of perspective. So that is something we all need to take away from this lecture and not base our decisions on MRI reports. Read them yourself, even tweak with the MRI if you can, and you would get your answer to a lot of things, and patients, especially the educated lot, get convinced by what you say. Thank you. So I have a kind of a algorithm that I follow. So a failed ACL-R, I thought it's pertinent for all the surgeons that are starting to do revision ACL reconstructions. Number one, rule out infection. That's a different category altogether. History, very important. What does the patient feel? So he'll tell you locking. He will not tell you I felt unstable. So remember, speak to him. Find out what is his issue. Why has he come to you? Clinical exam. Of course, look at other ligamentous injuries, meniscal injuries. Very, very important. Locked knee. That will give you an indication. Gait. Look for any lurch. So if there's a lurch, your ACL alone may not help. You may have to do a bony procedure in these cases. Look at gross alignment. Very important. While examining him also. Implants used. Bioabsorbable screw, lot of lysis. You know, it may affect whether you can do it in a single stage or a double stage. 2-stage. Technique. What was the technique used by the surgeon? That's very important to know. So what do? I do long leg films. I do an MRI. I do a 3D CT for tunnel position. And of course, a lateral view X-ray with the upper 2/3 of the tibia seen to check my slope. And lastly, remember, be open-minded, be ready to do a single stage if you can. So arthroscopy will give you a lot of information ultimately, which a lot of this imaging, in spite of being very, very organized in evaluating your patient, the ultimate thing that you see, the arthroscopy does lend a lot of information. Supplement your fixation with an extra-articular procedure. So if you're going to do a fixation, make sure that you do a remnant preserving if you can. It's a good idea, though there's not much literature to actually prove that that helps. But going by logic, biology helps. In primary, remnant preservation has been shown by a Japanese group to be very, very effective in ligamentization. So supplement your fixation for better stability and consider osteotomy. Though a lot of our patients, it will be very hard for them to digest it, but always think the previous surgeon is also an intelligent surgeon and he may have done a good job, may have been a biological failure. It can happen to you. So you need to do something else. You may have to do something else, especially in high demand patients, to give them the prescribed result that the patient is expecting. Thank you.
Thank you, Dr. Vikram. Excellent cases. And we have got many good things to see. So, Sonan sir and Kanchan sir, I'll request you and obviously we'll invite comments from Maheswari sir, special tips and tricks, and then we'll summarize the meeting.
Yes,
I think let's.
Maheshwari sir.
Yeah.
Yes, Kanchan sir, Kanchan sir.
No. Let's see what Jitan has to say.
Of course. So one is that there is going to be an epidemic of revision ACL. The reason is a lot more people are doing it now. I think it looks like the easiest arthroscopic surgery. Meniscus repair is meniscus surgery, even meniscus excision is actually more demanding than ACL because it's right there. Everything is open. And I've seen a lot of places, even the technicians do it. You know, the company fellows, they come and they tell the surgeon, do it that way, this way. So that is the reason why poor assessment and all these, travel by the bag kind of surgery, where you go, patient is in the OT already and you are supposed to do ACL reconstruction. You have never seen the patient before. And these are the reasons why the numbers will go up. Now, one aspect I want to touch, and Suendru has already touched on it. What can we do to avoid biological failure in the first surgery? For example, you already said you can add ALL if it is very explosive or you suspect ligament laxity. As a first operation, you can always add ALL. That's one thing one has to remember. What is the role of things like internal bracing and, of course, preserving the stump, restitching the stump? That's what, of course, Vikram does quite a bit. I don't know what it means. But what is the opinion of the other people as to preventing biological failure? Good tunnel, everything perfect. You're a good surgeon, but you want to prevent biological failure by one of these techniques. What is your opinion on that?
I'm not a very fond believer of internal bracing because it's supposed to act as a check. For whatever reasons, I'm not very fond of it, except in sometimes when I used to do it for the lateral collateral ligament. But with ACL, I think we don't have much to help biology along, except that we do surgery in a pristine way and don't damage things and leave as much of the inherent tissue there. Do as little use of cautery, as little shaving as possible to leave as much of the nature there. Like we've always been taught, do as little as possible for the best results. But in any case where there's a chance that the failure is going to happen, there adding some device like an AL or LET, which will act as a prevention for putting the initial ACL at risk, is something that I contribute to more and more nowadays.
Kanchan, can you give two very clear indications for young surgeons where they should not hesitate and go ahead and do LET in a primary case?
Primary case. Number one, explosive pivot shift. Number two, for all patients who are hypermobile joints, young but skeletally mature hypermobile joints, and be always think in terms of adding it to women.
Good.
Yes, Dr. Gopinath, anything for the final comment? Then I will just wind up. You have to unmute yourself, Professor Gopinath.
Internal bracing is always controversial, and a lot of techniques, the artificial grafts, they have all failed, and the long-term follow-up, we don't know. So as far as possible, only innate grafts and collagen grafts are better than internal bracing. But particular procedures, we can always go for materials like that. And also in all cases where there is explosive pivot shift, we have to concentrate on the posteromedial part of the meniscus. Many times it's a ram lesion or an avulsion or even a meniscal injury, which gives a lot of posteromedial. Most of the time, the explosive, the pivot shift will disappear, and you have to think twice before you go into the elite.
So I might be looking bit parts that I don't I don't have that caliber of doing this internal bracing. I've never done internal bracing because in internal bracing, even it came into the market, it could not be, I could not put it inside my brain. So one thing. Second is that I'm really been very much perplexed. I am really very apprehensive at how the people can resuture the femoral stump to the femur, and it is again going to heal. There are a lot many people doing it, but I have never done it. Kanchanda, Jiten sir, they might be telling because I am really afraid because it is not going to. I am sure that it is not going to work in my hand.
But
Jiten
in
sir,
acute cases, when in acute case where there is a real avulsion and the ligament looks normal, and if you are lucky to operate early, I think it will work. You can attach the ACL to the femoral tunnel using a push lock, or so many implants are available, and it will heal. We have a few cases we did that within 1 week of time, 3 to 5 days. If you are able to operate, a femoral avulsion can be repaired. ACL repair is still a possibility.
yes, people are telling that even up to 4 weeks they can do it. They are doing it up to 4 weeks. Kanchanda, your opinion? How many you have done? Actually, the femoral this resuture.
See, I don't do it. I don't do it because Jiten and I, we know about Bosota's technique of repairing. Never worked well. So, again, I'm not sold on this.
Jiten sir?
But that's a different topic. But I think our experience of repairing is almost 80% avulsion from the femur. Sometimes you can't say it is avulsed from the femur exactly, but when you can see on an MRI, almost the whole ACL is intact. Particularly in low-key people, we have done now about a dozen, and broadly speaking, we are very happy with the results. In fact, one patient, I did a ACL reconstruction 5 years back. He tore his second ACL, and this was a repairable one, and we counseled him. And now after 2 years of having repaired this, he says my repaired one is much better than the reconstructed one. So, some of these things give you anecdotal confidence that somehow something happens when your God-given ligament, which has blood supply, everything, is likely to actually do better than your dead ligament, which will get revascularized, re-ligamentized, blah, blah, blah. So I think our threshold for repairing has gone down after this little bit of experience. But we are very choosy, very selective.
Yeah. The thing is that what is your cutoff time limit, sir?
Maximum 2 to 3 weeks. 3 weeks maximum, you can say.
3 weeks. Kanchanda, you told that you have never done it. Gopinath, no. Your choice of cutoff time?
Usually we operate within a week to 10 days, and use an implant, a push lock, and we never repair the ACL which is avulsed from tibia, only from femur. If it is avulsed from femur, it is still a possibility.
It is from the do you tell patient before I am going to repair from the MRI picture? Can you judge that I am going to repair it? Do you tell that patient, or is this a part of decision?
We give the option. We give the option to the patient. If you operate any ACL within 10 to 7 days or 10 days or within 14 days, we give them an option. And especially if you see the MRI and see that it is avulsed from the femoral side, we give an option. If possible, we'll repair it, and rehabilitation also we'll discuss.
Okay. Understood. So I think we have, if I were taking the permission of Professor Gopinath, Jiten sir, that if you tell me that we can summarize, it was an extensive session. We have more or less covered like everything with the whatever is possible from the revision ACL, more or less taken like 2 hours and 15 minutes. And nice cases, Vikram. In between, when I missed your second case because my net was not proper, so I have to connect with the mobile. Probably I don't know how long it is going to work, but probably when you go with the revision ACL, maybe counseling. Second thing, Professor Gigi Kaur told us how to investigate. It doesn't mean that investigate is just your X-rays and MRI and CT scan. Investigate mean your clinical picture, your history, and you must be sure 100% that you have not missed any of the single associated collateral or the corner injuries. Okay. So if you have a revision scenario, then you go with the MRI. You can do the CT scan. Please never forget to take a hip, knee, ankle X-ray, because sometimes the primary go was the alignment was not right. If your alignment is not right, probably you are going to fail. Second thing is that whenever you judge the failed ACL, always try to see the gait, because I think Gopinath sir has already given us the double varus and triple varus. The double varus means varus along with the lateral opening. Triple varus is varus, lateral opening, along with is recurvator. So if these components are there, then your revisional ACL surgery is always a complex surgery. So it is not only the question of the laxity, sometimes even your osteotomy only, rethink about the slope. Sometimes if you do the corrective osteotomy also, this can help. The problem is, Gopinath sir has already told that the opening wedge surgery is the medial opening is probably one of the solution for the ACL surgery. But I will just caution the juniors that whenever you do the open wedge osteotomy, the inherent problem with the open wedge is the increase of the slope. So when you do your open wedge from the medial side in ACL revision, please remember that when you do the open wedge on the medial side, you have to correct or reduce the slope by putting your graft on the back or your implant on the back side or your laminar spreader on the back side, so you don't increase the slope. So I think these are the very, very important points I have been learned over the years, and also I'm still learning from every time from Jiten sir, Kanchan sir, and always Gopi is a great teacher. So I think these are the few points. And the junior guys like Vikram, how they are doing, I'm really been proud that at his age, probably we have not been so much learned, so much skill we had. Still we lag behind because I'm envious that how they have learned in their young age. And Arnab also, he is doing a great job in arthroscopy, both in knees and shoulder. So I think we are really envy. We are still learning from the juniors itself. Vikram, your cases were too great. Okay. So I think we can, these are the few points that we can take home today. So we tried our best to have the best faculties throughout the country. So I think Dr. Gopinath, this is the way we have summarized. Have I missed any points?
Great, great.
Okay. Kanchan sir, have I missed any point? I think the summary, have I missed anything?
No, you've done great, and thank you very much. I need to leave now. I've got another place to go.
Okay, okay. So I think we have so Vikram, okay. So now they just 30 seconds be with us, because they have organized. The organizers will give the final comment from their side.
Yes, yes.
It's just 30 seconds. No problem.
Yeah. Good afternoon, delegates. This is Ranjit Kumar, National Sales Manager for Alembic Pharmaceuticals Limited. And on behalf of Alembic, I would like to thank our moderators, especially Dr. Swanendu Samanta sir and Dr. Arnab Karmakar, for bringing this topic of ACL revision for the benefit